Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is lung cancer. Lung cancer is responsible for approximately 35,000 deaths per year in the UK from bronchial carcinoma alone. This makes it quite a common MRCP topic and is likely to come up in either of your exams. The male to female ratio for lung cancer is approximately 2:1. There are some common histological cell types to be aware of, which are commonly used in subclassifying lung carcinoma. These are primarily divided into small cell and non-small cell, and within non-small cell types, there are adenocarcinoma, large cell, and squamous cell. There are certain symptoms, common and uncommon, to be aware of when assessing someone with potential lung cancer, as well as to look out for in MCQ vignettes. Some of the more common symptoms, which those of you working in medicine would be familiar with, are breathlessness, cough, hemoptysis, chest pain, and weight loss. Some of the more uncommon symptoms to be aware of, however, include symptoms such as wheeze, dysphagia, hoarseness, and other presentations such as Horner's syndrome and superior vena cava obstruction, or SVCO. If a person with potential lung cancer presents with confusion, this can be due to a number of causes, including SIADH, hypercalcemia, or brain metastases. Cushingoid features can also be seen in people with lung carcinoma, as we will find out on subsequent slides. In terms of common signs to look out for, and this is particularly pertinent for PACES, again, these can be divided into uncommon and common signs. It's important to check the hands for clubbing and tobacco-stained fingers, as well as general inspection for cachexia and pallor. In terms of other signs that you may find in someone with lung cancer, these include lymphadenopathy, as well as consolidation or a pleural effusion when auscultating the lungs. It's also important to perform an abdominal exam, as there may be features of hepatomegaly. Facial swelling may also be evident when looking from the end of the bed. Lung cancers can be associated with paraneoplastic phenomenon. These include Cushing's, which involves ectopic production of ACTH, and this is seen most commonly in small cell carcinomas. SIADH, which is due to ectopic ADH production, also seen in small cell. Hypercalcemia, which is due to the production of parathyroid hormone-like peptide, which is seen in squamous cell subtypes. There is also hypertrophic pulmonary osteoarthropathy, which has an unknown mechanism and is seen in non-small cell types. And finally, Lambert-Eaton, which is due to the presence of antibodies against voltage-gated calcium channels, and this is seen in small cell lung carcinoma. As with most conditions, particularly in the case of something such as lung cancer, history and examination is vital, particularly a social history, including a thorough smoking history, as well as occupational exposures. Blood tests should be performed, including inflammatory markers, a full blood count to check for anemias, amongst other things, renal function and liver function tests, as well as electrolytes, including magnesium and calcium, particularly looking for hypercalcemia. A chest x-ray should be performed as quickly as possible if anyone presents with any of the symptoms listed previously, as you would do in the acute setting, but particularly also if someone is presented with a chronic history of weight loss, for example, or other constitutional features. A CT chest should then be performed, particularly if a mass is discovered on the chest x-ray or any other abnormalities, and this can be performed alongside an abdomen and pelvis CT scan. Bronchoscopy is the gold standard for tissue diagnosis of lung cancer. If a further, more detailed imaging is required, a PET CT scan can be performed. With regards to management of lung cancer, the first piece of advice to give to patients is smoking cessation, which is key. Beyond this, management can be divided into surgical, medical, and palliative. Surgical options include lobectomy, pneumonectomy, and lung transplant. Medical treatment includes chemotherapy and radiotherapy. Palliative treatment for lung cancer includes pain control, particularly in the presence of bone pain, as well as management of breathlessness and respiratory secretions. So now time for some questions. The first question is, a 60-year-old man with a 20-pack-year history of smoking presents to the acute medical take with a 3-month history of unintentional weight loss of 2 stone and fatigue. His serum sodium is 127. Given the likely diagnosis, what is the next most appropriate investigation? So our options here are sputum sample and culture, PET CT scan, endobronchial ultrasound or EBUS, high-resolution CT scan or HRCT, or a chest X-ray. So in this case, the correct answer is a chest X-ray, just given those symptoms that the patient has presented with, and is the most easiest and efficient form of imaging to get in the acute setting. Question 2. An 85-year-old lady presents to the ambulatory care unit with a 4-week history of confusion. On examination, the IMT1 doctor notes bilateral digital clubbing, as well as a non-tender 4cm supraclavicular lymph node with associated unilateral ptosis. Her serum adjusted calcium level is 3. Given the likely diagnosis, what is the most likely subtype of malignancy? So this requires you to think back upon the paraneoplastic syndromes that can be associated with the various forms of lung cancers. So our options here are small cell, large cell, squamous cell, adenocarcinoma, carcinoid. The correct answer here, which you may recall, is squamous cell, and it is important to try and remember which forms of paraneoplastic syndromes are associated with which types of lung carcinoma, as this can be quite a common question in the MCQ exams. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.